Okay, so this next section, we're going to start off with shoulder impingement syndrome. Um, this shoulder impingement syndrome is kind of a catch-all term for shoulder pain that does not involve specifically the AC joint or the SC joint. Um, it really doesn't involve any kind of ligaments around the glenohumeral joint. It's going to be kind of like the shin splints of the shoulder. It's going to be really important to understand the anatomy when it comes to understanding how to figure out what's going on with impingement syndrome. So we've mentioned it before, but when you look at the shoulder and the anterior side, you have the coracoid process. Then you have your acromion process coming off the scapula. So both of these are on the scapula. Then you have your coracoacromial ligament that ends up forming this entire arch that runs from the coracoid process to the acromion process. So we get this arch. Running underneath this arch is several important things. First of all, one of the biggest ones here is going to be your supraspinatus tendon. Supraspinatus is going to originate in the suprascapular fossa of the scapula. It's going to run underneath this arch and insert on the greater tuberosity. So it is a primary structure that's going to be in this arch and one that's primarily injured during impingement syndrome. We also have the long head of the biceps tendon, which runs through the bicipital groove all the way up to the supraglenoid tuberosity of the on the glenoid fossa. We also have this blue structure here called the subacromial bursa. So subacromial, below the acromion, there is this bursa. Remember that bursa are always depicted as these balloon type of structures, but in reality, when the bursa are not actually inflamed, I always think of them as the second skin. There's little squares that you put over blisters that are sticky and jelly, but when they're in the body, they're not going to be in the body, but when the bursa are in the body and they're not irritated or inflamed, you can't even tell that they're there. Their purpose is friction reduction. So they are these areas of lubrication where they're in high areas of friction to help just move things along. When they start to become inflamed, you may be able to palpate them. So a subacromial bursa is there. We also have the capsule that surrounds the entire glenohumeral joint, and then obviously the humeral head is also under there as well. So looking at this from the lateral side, so we're looking straight into the body. In this case, here's our coracoid process, and here's our clavicle. Here's the acromion and the spine. So over here is going to be the anterior side. This is anterior. This is posterior. So looking at this, you can really see what the arch looks like. Here's your coracoid process, here's your coracoacromial ligament, and here's the acromion. This is forming that arch. Underneath there, you have the long head of the biceps tendon, you have your supraspinatus tendon, humeral head. The bursa is not depicted in this picture, and the capsule that obviously surrounds the entire glenohumeral joint. So when we have shoulder impingement syndrome, a lot of times this happens when we reach our arm above 90 degrees. During overhead activities, you're going to be at high risk for shoulder impingement syndrome. But what's happening is just structures are getting pinched or impinged in that arch. So as the arm is raised, the greater tuberosity is being shoved up into this subacromial arch, and it's actually pinching some of those structures underneath, whether it's the bursa, whether it's the long head of the biceps tendon, or whether it's the supraspinatus. Something is getting pinched and is causing pain and irritation. Now, there are several reasons why we can get impingement syndrome. We call them primary compression or secondary compression. Primary compression occurs generally because there's actually a structure in the way. Something is taking up too much space, and that's why we have this compression, and that's why we're getting impingement syndrome. So primary compression, when something is actually in the way, can be caused by an irregularly shaped acromion. Sometimes our acromion can form hooks. I'll talk about that a little bit more later on. We'll look at the specific pictures. But they can form hooks, and that hook can actually project down into the subacromial space where the structures are running. So it can actually start poking into some of those soft tissue structures, obviously causing pain. Depending on where the coracoacromial ligament is, it could actually be sitting a little bit lower, causing you to have a little bit less space. If your bursa has been irritated, then they can become enlarged, taking up more space, leading to pain and dysfunction. And then if we have a thickened rotator cuff tendon, possibly as a result of long-term impingement syndrome, but it is now taking up more space, leading to this primary compression idea. Then we have secondary compression. Secondary compression is really not a result of any specific structure. It's going to be a result of some other things. So for whatever reason, we are pinching these structures. It could be primary compression because something is too large, taking up too much space, and structures are getting pinched. Or it could be something like loss of humeral head depression. When we do overhead activity, the rotator cuff is responsible for keeping our humeral head on the glenoid fossa. If the humeral head starts to move off the glenoid fossa and kind of do whatever it wants and has a lot of motion, it's going to start pinching structures, specifically structures in the subacromial space. The supraspinatus specifically, because it runs on top of the joint, the supraspinatus is responsible for keeping the humeral head in the glenoid fossa and keeping it from rising up too high. So the supraspinatus is responsible for depression of the humeral head. The other three rotator cuff tendons are responsible for more the internal rotation and external rotation and keeping it in place front to back, where the supraspinatus is responsible for the depression. So as the shoulder starts to go up, instead of it rolling out of the glenoid fossa superiorly, the supraspinatus actually pushes it back down and keeps it in the glenoid fossa. So if that's not working correctly, and if during activity the supraspinatus is not doing its job, then the humerus is going to be rolling up superiorly and it's going to be crushing some of those structures, causing this impingement. Poor posture is another one that is going to be an indicator for impingement syndrome. This is what this picture is about. So if you can kind of see in here, this person has good posture, and we have a little bit better arch. Kind of the arch is not huge, but when we look forward to backward, it's kind of, there's space throughout. When we look at this one, we have more, because we have forward shoulder posture, we actually have more space in the front and less space at the back. So this forward shoulder posture is actually decreasing the space under the subacromial, in the subacromial arch. And because there's just decreased space in general, if they do overhead activity, there's less space to work with, so those structures are going to get pinched. And then general repetitive overhead movement. When we spend a lot of time overhead, you're just putting your body at higher risk for impingement. When you do things overhead, you have your greater tuberosity that's coming up and actually pinching those structures underneath. So all these are a result of secondary compression. Some people might just have one of them. Some people might have them all. So someone might have poor posture, and then they decide to do repetitive overhead movement, which is putting them at risk, and then maybe their muscles start to fatigue, and now we have a loss of humeral head depression. Or it could be perfectly good posture, but they just have poor muscle tone, so they can't keep their humerus in place. Or they have good posture, and they do a lot of repetitive overhead activity. It's fatiguing their muscles, and then they have a loss of humeral head depression. Either way, whatever's going on here, we want to try to identify the problem. If it's posture, you have to address the posture. Usually, the humeral head depression and repetitive movements go together, and we need to work on endurance training of the rotator cuff muscles so that they actually work effectively during activity. Kind of a side note here, we have this thing called GERD, not GERD as a gastrointestinal anything. This is GERD, called glenohumeral internal rotation deficit. That's what GERD stands for us. And this is kind of a condition, not necessarily a problem, but it's something that is common in baseball pitchers, or just kind of overhead throwing athletes or hitting athletes in general. GERD can be a problem. Well, what it is a whole lot of external rotation and not very much internal rotation. So, like in this picture, here's the guy lying on the table. Normally, we start the person at 90 degrees. So normally the arm goes here for external and there for internal, where it's about 90 degrees of external rotation, 90 degrees of internal rotation. But in this baseball pitcher, the arc has actually shifted, where it's still 180 degrees because his arm goes from here to here versus here to here. It's just shifted. So now he's got a lot more external rotation and not very much internal rotation. So that's where we get our glenohumeral internal rotation deficit. In this case, he does not have very much internal rotation. This may or may not be problematic. This internal rotation deficit, what it does is actually, it happens over time because in order to get a fast pitch, you do a lot more external rotation. The further back you can cock the ball, the more time you have to throw it, the more force you can put on the ball. So these pitchers over time develop a lot of external rotation. Then they start to lose internal rotation because when they are decelerating and following through from that pitch, it actually starts to tighten up the posterior structures. The posterior shoulder structures, they're working so hard to slow down that arm movement that they actually become shortened over time. And that's going to be one of the reasons, tight posterior capsule is going to be one of the reasons why we lose our internal rotation. So it generally is decreased internal rotation with a larger external rotation when we see that in the 90-90 position. And we see it a lot. It's a result of a tight posterior capsule. The problem is, if untreated, it can result in possibly a slap lesion, your superior labrum anterior to posterior tear of your labrum, or it could result in posterior impingement syndrome, just general shoulder problems, shoulder pain. So we try to deal with this, and a lot of people have put baseball pitchers on internal rotation stretching programs. What we have seen is something that's kind of a newer thought process, where a normal person will say have 90 degrees of external rotation, 90 degrees of internal rotation for a total of 180 degrees. Then you see a baseball pitcher who might have 120 degrees of external rotation and 60 degrees of internal rotation on their right arm, on their throwing arm. So they still have 180 degrees, which is normal for them, but that arc has kind of shifted a little bit, where they have more external and less internal. What they found is sometimes when you're doing overhead throwing sports for so long during your life, your humerus actually starts to rotate. We have humeral torsion. And because your humerus rotates while growing, it actually stays that way. So you're not going to have, no matter how much you stretch, you may never actually get normal range of motion, the 90-90, because while you were throwing, so much force has been placed on your shoulder that you actually developed a lot more external rotation, less internal rotation, but it's how your bone is actually formed versus being an actual range of motion deficit. The way you can tell the difference, generally speaking, is you want to measure the person's non-throwing arm and get the total range of motion. So, for example, if their non-throwing arm has 80 degrees of internal rotation, 90 degrees of external rotation, that's 170 degrees. So that's, we'll say, is, since it's their non-throwing arm, we'll say that's normal for them. Then we measure their throwing arm, and we see the 120 degrees of external rotation and, 50 degrees to give us the 170, 50 degrees of internal rotation. So obviously a lot more external than internal. That may not actually be a problem because both arms have a total range of 170 degrees. The right arm, or the throwing arm, is going to have more external, less internal, but it still has the same overall range of motion. When it's a problem is when we see if the non-throwing arm has a total of 170 degrees and the throwing arm has a total of 150 degrees. Now that's a problem because the total range of motion is different, and that's going to be because there's actual range of motion deficit versus humeral torsion. If you have any questions on that, I can explain that again later in class, so just make sure you ask. One of the big things we're going to see in terms of impingement syndrome um, is really going to be about fatigue. And because the structures that the static stabilizers in the shoulder are so poor, we have to rely a lot on our muscles. So if our muscles are too fatigued to work, then it's going to put us at risk for injury. So repetitive overload, whether it's too many pitches at one time or too much activity at one time, or more of a chronic overload where it's getting toward the end of the season and you've been pitching a lot, that's kind of a chronic overload, so chronic fatigue. So it could be, again, too many pitches, you're pitching 150 pitches in a game, your body starts to fatigue. Or you've pitched all season a lot of pitches per game, and now you're just overly fatigued. Either way, that's going to affect your muscles. If your muscles are not able to contract effectively, it's not going to control your humerus, and you're going to be put at risk for impingement syndrome. You see this a lot in the major leagues when they say they're going to shut a pitcher down for an extended, for a little bit, because they have identified that this person is developing impingement syndrome, and really the only way to fix it at this point is to rest the muscles and then start to work back in rehab. If they continued on and push through the pain, it's only going to get worse. So fatigue is if your muscles are not able to contract eccentrically to slow your arm down, you're going to put yourself at high risk for this overuse injury. And then sometimes not about fatigue, but it could be scapular dyskinesis, where your scapula is out of rhythm. Maybe it's not working correctly. Maybe it's not being stabilized to your body correctly. Maybe you have winging scapula, like in that picture there. Whatever it is, if your scapula is not stabilized, then your humerus is going to have to do more work. Like I said before, you're only as strong as your core is, while your arm is only going to be as strong as your scapular stabilizers are. So if your scapula is not stabilized, then you're going to be at high risk for injury. Rotator cuff muscle weakness, even without fatigue, if they're just not able to withstand the forces that you're applying to it, then you're going to end up developing impingement syndrome as well. So the muscles are just not strong enough, they're not able to contract enough to hold you into place. That could put you at risk for injury. And then general glenohumeral joint instability. I've said it before, your capsule is already not very strong, your ligaments are already not good. If in general you are lax and especially unstable, then you're going to be at higher risk just because your static structures are not as good. So the scapular dyskinesis and the rotator cuff weakness, that's all about dynamic stability. But if you have, even as poor as our stabilizers are, they still do something. And if you don't even have that static stabilization, then again, you're going to be at higher risk for developing some sort of shoulder impingement syndrome. So it's a big, huge explanation of why it happens. But what we're actually going to see here is pain during overhead motions, especially motions where with internal rotation, where we see the greater tuberosity put into the subacromial space. When that happens, it actually takes up more space, causing more pain. We see some relief of symptoms when the glenohumeral joint is in slight abduction, where it's not all the way against your body, but in slight abduction. But they're going to give you general complaints, dull, diffuse type of pain. They can probably tell you where the pain is at, but you're not able to actually feel where it hurts. So palpable point tenderness is not really there. They can point to an area, and usually that area is directly underneath the acromion. They will feel the pain inside underneath the acromion because that is where the supraspinatus tendon is. When it comes to impingement syndrome, it could be, we don't really know what structure is involved. It could be the bursa. It could be supraspinatus. It could be long head of the biceps tendon. We don't really know what structure it is, and that's kind of okay because we understand that this symptom is such a small area, we're not able to necessarily figure it out specifically. But the big picture, even if it was supraspinatus, or it was bursitis, or it was long head of the biceps tendon, it doesn't really matter because you're going to treat it the same way. So that's the positive thing, where even if we don't know what specific structure it is, we're still going to have the same kind of rehabilitation. The two main tests are Neer's test and Hawkins-Kennedy test for impingement syndrome. Both are pretty good tests at identifying impingement syndrome.